There you are, Dr. Sagel. Have fun with our kids.
Thank you. Chris, thank you. Hi, guys. I'm Scott Sagel. I'm a pediatric pulmonologist at Children's Hospital of Colorado. There's a variety of different lung diseases that I'm involved with, most common being asthma. There's certainly children who are born early and prematurely, whose lungs don't develop, who develop a form of lung disease of prematurity. But the disease that I focus in particular on is I focus on children with rare genetic lung disease. And one of those diseases is cystic fibrosis. And it's a disease that really is a nice segue into things that you guys have been learning in biology class, where you've been talking about genes and proteins in the body. And cystic fibrosis is a disease that results from mutations in a gene that leads to abnormalities in a protein that plays a very important function in our body. And so we're going to talk about cystic fibrosis under that context, knowing that we are really in an exciting era, an era where we're able to improve or augment the defective CFTR in the body with what we call CFTR protein modulator treatment. And we're embarking on a future in which we will soon be able to fix or repair the defective or abnormal gene in people with cystic fibrosis. So it's really an incredibly exciting time, not only for those living with CF, but for people like me who are involved in the care and treatment of those with CF. As this session is being recorded, you'll see here that my email address is here. If you guys have questions about cystic fibrosis or questions about pediatric pulmonary medicine, feel free to reach out at any point. So with that, we'll get started. So cystic fibrosis has certainly existed since the Middle Ages, and we have several examples that its manifestations were recognized, such as this quote from a 17th century German folk song, that the child will soon die whose forehead tastes salty when kissed. However, it wasn't until the 20th century that CF was determined to be a disease and a diagnosis could be made. Karl Landsteiner recognized the earliest clinical manifestations of CF, the neonatal bowel obstruction that we call meconium ileus, which affects about 10 to 20% of babies with cystic fibrosis. In 1938, Dr. Dorothy Anderson, a pathologist at Columbia University, published an extensive autopsy study of infants who were suspected of having celiac disease, who died of chronic diarrhea, malnutrition, and pneumonia. She identified mucus plugging of the ducts of the pancreas that resulted in the formation of cysts and scarring, or what's called fibrosis, in the pancreas. And she used for the first time the term cystic fibrosis of the pancreas, which was later shortened to cystic fibrosis, to describe the findings in these infants. And in 1948, there was an intense heat wave in New York City. Several infants and young children who were suspected of having cystic fibrosis, but at that time was still, again, recognized as being some form of a severe form of celiac disease, were admitted to the hospital because of heat prostration and severe dehydration. Dr. Paul D. St. Agnes, pictured here, recognized that these children were losing excessive salt in their sweat, and it led him to be able to develop a test to be able to measure the chloride content of sweat. Fluoride is one component of salt, chloride and sodium, but be able to measure the chloride content that became the basis for being able to diagnose cystic fibrosis. So back when we were able to identify babies with this condition and make the diagnosis in the 1940s and 1950s, CF was a devastating disease. Children died in the first decade of life and often in the first few years of life. These pictures are showing you pictures of these infants with a condition that we refer to as kwashiorkor, which is a form of protein calorie malnutrition, where they have these swollen, protuberant bellies, skinny, emaciated limbs, and they're edematous. They have excess fluid in their tissues because of low protein circulating in their bloodstream. They died early because of the digestive abnormalities and the pulmonary abnormalities, the pneumonia. So two fundamental aspects of life, breathing and digestion, were critically impaired. And that's why these kids died early in life. So what is cystic fibrosis? CF is a syndrome of chronic sinopulmonary infections, malabsorption, and nutritional abnormalities. It is one of the most common lethal genetic diseases among Caucasians. And when I started my medical training in the 1990s, at the time it was the most common lethal genetic disease. But because of successes and being able to improve survival in people with cystic fibrosis, it's now one of the most, as opposed to the most common. CF is inherited in an autosomal recessive fashion. Many of you know what that means, but there are particular traits that are passed down from generation to generation. And traits that are passed down in an autosomal recessive fashion means that you have to have two abnormal copies of the gene, one from mom and one from dad, to have the condition. If you inherit one abnormal copy, you're a carrier. So that manifests itself in autosomal dominant conditions. But something like cystic fibrosis, you need two abnormal copies of the gene, one from mom and one from dad, to actually get the disease. Median predicted survival in cystic fibrosis is now in the mid to upper 40s. And why does CF happen? Again, because there's a gene in our body, the CF gene, that encodes for a protein that we call the cystic fibrosis transmembrane conductance regulator protein. Big words, so we abbreviate it the CFTR protein. CFTR protein functions primarily as an ion channel, helping to control the movement of salt and water into and out of cells. Now I'm going to have a couple of video files that will show you how the CFTR protein sort of looks in the cells and how it functions. In terms of the manifestations of CF, CF is a multi-organ disease, meaning that multiple organ systems throughout the body are affected by CF. And it's the organ systems in which the CFTR protein is normally expressed. Now, I'm a lung doctor, so I care in particular about the sinopulmonary disease manifestations of cystic fibrosis, which includes mucus obstruction in the airways, infections with bacteria and fungi that ultimately culminates in damage to the airways, something we call bronchiectasis, and then lung collapse called atelectasis. But there are many other organs that are affected. I alluded previously to the digestive abnormalities. Well, it turns out, the pancreas is a critical organ in which abnormal CFTR leads to disease consequences. About 85% of people with cystic fibrosis are pancreatic insufficient, meaning that they don't make enough, they don't get enough of the digestive pancreatic enzymes into their intestines to be able to adequately digest and absorb fats and proteins they eat. So we sort of know there are three large food groups: fats, proteins, and sugars. The problem in CF centers around abnormalities in digesting the fats and proteins. And so those 85% of people with CF who are pancreatic insufficient, they need to take digestive enzymes by mouth before every meal they eat, every meal in which they're consuming either a fat or a protein. So you just think of a glass of milk or any type of a hamburger, anything in which there's fat and protein, they need to take digestive enzymes before they have that glass of milk or that hamburger before they eat. Those who don't have pancreatic insufficiency, who don't require enzymes, many of them are at risk for developing pancreatitis because of chronic inflammation in their pancreas. Another part of the pancreas that's affected is the endocrine part of the pancreas. So the pancreas sort of has two roles in our body. It makes the digestive enzymes that get out of the body into the intestines. We call that the exocrine part of the pancreas. The endocrine part of the pancreas are islet cells that produce insulin in response to sugar loads in our body. And so because of the damage and destruction of the pancreas, eventually they get damage to the islet producing cells of the pancreas, and they develop their own form of diabetes, which, like type 1 diabetes, they often require insulin therapy. They also get other endocrinology type abnormalities such as bone disease and stuff. I mentioned a neonatal intestinal obstruction called meconium ileus that affects about 15% of people or babies with CF, and the older person equivalent, something we call distal intestinal obstruction syndrome, a severe form of constipation that people with CF get. While the vast majority of people with CF die as a result of their lung disease, over 90%, another significant morbidity is liver disease. About 5% of people with CF die as a result of liver failure due to cirrhosis or scarring in the liver. So this is also another organ that's impacted. I mentioned that heat loss, dehydration, because the CFTR protein is in sweat glands, plays a role in the absorption of salt. And so if it's not working properly, they lose salt in their sweat, and they're at risk for salt-losing dehydration and a condition we call metabolic alkalosis. And then the other thing is the reproductive system is affected by people with cystic fibrosis. Almost all males with classic cystic fibrosis are not able to reproduce by traditional means. They're not sterile. They make sperm, but because of congenital bilateral absence of the vas deferens, their sperm is not able to make it into the urethra. And so they can still conceive using advanced reproductive techniques, but there are these reproductive abnormalities, both in men and women. There's also, I'm just showing you here, a quick pathophysiologic cascade of cystic fibrosis, where it begins with mutations in the CF gene that leads to abnormalities in the protein, in the CFTR protein, resulting in a dehydrated airway surface liquid layer and a cycle of mucus obstruction, infection, and inflammation. So this graphic is showing the improving survival in people with cystic fibrosis and the associated therapies and milestones that have led to the improved survival. So the first treatments that became available to people with cystic fibrosis included these pancreatic enzymes or digestive enzymes that were derived from pigs, penicillin and other antibiotics that were developed in the 1950s, 60s, and 70s, and then various mucus clearance treatments, most commonly chest physiotherapy. The very first CF-specific treatment that was approved in cystic fibrosis is an inhaled mucolytic therapy, a therapy that helps to liquefy, break down the thick, tenacious mucus in the airways of people with cystic fibrosis, and it's called recombinant human dornase or dornase alpha. A bacteria that's a particular pathogen causes problems in people with cystic fibrosis is a bacteria called Pseudomonas aeruginosa, and it's a bacteria that was associated with increased morbidity and mortality. You died when you had this bacteria. So a couple of specialized inhaled antibiotics were studied, developed, and eventually approved as chronic therapy for people with cystic fibrosis and chronic infection with Pseudomonas, in a form of inhaled tobramycin and a form of inhaled aztreonam. And then the latest really breakthrough in treatments in the last decade have been the development of a class of therapies we refer to as CFTR modulator therapies, therapies that target the basic defect, the CFTR protein abnormality. And the first one in the class of this class of therapies, something called ivacaftor or Kalydeco, and we'll look at that therapy momentarily. So this really shows why people with cystic fibrosis die. So this is a pathology or autopsy specimen of a lung in cross-section, where you see these very dilated airways. Normally, if we cut open a lung, you might be able to see very small airways, and eventually at the branching ends of the airway tree, they're too microscopic. You can't see them by the naked eye, but you can see these are very large dilated airways that are filled with mucus. And in this mucus is infection with particular bacterial and fungal pathogens and the body's own inflammatory response. It's as if they drown in their own secretions. So why does this happen? Again, if we refer back to our pathophysiology, really the critical abnormality is the depleted periciliary liquid layer, the liquid layer in which cilia function. So this is a normal cell here on your left. And the liquid layer, this periciliary liquid layer, is maintained by CFTR, which should be functioning at the cell surface to secrete chloride into the lumen of the airway. You have epithelial sodium channels, and sodium, tends to want to come together, bond with, or buffer chloride to form salt. Water follows to sort of maintain a nice homeostasis and to buffer that salt. So you've got this maintenance of this periciliary liquid layer that cilia can beat effectively in by the functioning CFTR, the epithelial sodium channels, and this movement of water. But in cystic fibrosis, shown here on the right, either because the CFTR protein is not functioning properly at the cell surface, or it never even makes it to the cell surface, you don't get chloride secretion into the airway, you get hyperabsorption of sodium back into the cell, and then water follows. So water goes into the cell, again to buffer the salt. You get a depletion of this periciliary liquid layer, and then mucus builds up. This is the disease pathogenesis, the lung disease pathogenesis in cystic fibrosis. So here's a nice video that sort of demonstrates this, where we're going to first look at normal mucociliary clearance, and then what happens with impaired mucociliary clearance in cystic fibrosis. So in normal circumstances, you have cilia beating in this nice lubricated periciliary liquid layer with a mucus layer on top of it. And that's because of this functioning CFTR protein in which chloride is secreted into the lumen and you get sodium going bidirectionally. But in CF, the protein doesn't work. Chloride does not get secreted into the airway, and as a consequence, you get depletion of this periciliary liquid layer and the mucus layer builds up. So something that's fundamental to our breathing, being able to clear mucus from our airways, is critically impaired in people with cystic fibrosis. So if we think about treatment for cystic fibrosis, again, come back to the reasons that CF happens. It begins with the mutations in the CF gene that leads to abnormalities in the CFTR protein, defective ion transport in the airway, and depletion or dehydration of that airway surface liquid layer, resulting in impaired mucus clearance, a buildup of mucus, and a cycle of infection, inflammation, and eventually scarring or fibrosis of the airway, culminating in end-stage lung disease. If we work backwards thinking about treatment, well, for those with end-stage lung disease, their only hope at survival at that point becomes a lung transplantation. Fortunately, this is something we rarely deal with in children now with cystic fibrosis. But there are many adults out there with cystic fibrosis who are alive because of having had a lung transplantation, or whose survival is dependent on receiving lungs in the near future. For many years, we treated the downstream consequences of CF. So those downstream consequences of mucus obstruction, infection, inflammation, well, we used a variety of different airway clearance treatments and inhaled mucolytic therapies to break up the mucus and make it easier to cough up, expectorate the mucus. We've used antibiotics have been a mainstay of treatment for people with cystic fibrosis to combat chronic infection in the airways. Inflammation, we use a variety of different anti-inflammatory approaches. You guys hear about steroids like prednisone or dexamethasone. There's an antibiotic that also has anti-inflammatory properties called azithromycin that we use a lot in people with cystic fibrosis. But for many years, it was treating these downstream consequences. We are fortunately, I mentioned in the title of the talk, in an era of CFTR modulation. being able to fix the abnormal protein with a class of therapies that we refer to as CFTR modulators. And we are investing millions of dollars in developing gene-based treatments. And so the next breakthrough in treatment, probably when many of you guys are going to be in your medical training, is going to be either being able to replace or repair the defective gene in cystic fibrosis. Great deal of work is going into that, and we'll end up our talk sort of speaking to those approaches momentarily. But I'm going to now sort of just spend just a couple minutes on this graphic, which just, you know, as a prelude to talking about protein-based and gene-based treatments. And that's thinking about the mutations in the CF gene and the consequences in the CFTR protein. So again, let's, you know, looking at this schematic here on the left-hand side, thinking back to our biology class, you go into a cell and you remind yourself how a gene works, that the DNA is in the nucleus of the cell. Segments of the DNA that we call genes are copied into strands of RNA. The RNA is processed into a messenger, or what we call mRNA, and it's exported to the cytoplasm of the cell, where it's translated by the ribosome into a protein, such as the CFTR protein. That CFTR protein then gets trafficked to the cell surface, where it carries out its function, in this case allowing anions like chloride and bicarbonate to move across the cell membrane. Now, CF, there's one gene for CF, but there are approximately 800 mutations in the gene that are known to cause or lead to cystic fibrosis. And this is one way of classifying those mutations in terms of the consequence of the protein abnormality. So there are class 1 mutations, things that we typically think of as nonsense or stop codon mutations. Not important you guys know these letters, these nomenclatures, but I'm going to still say it because you're going to learn about genes and mutations over time, many of you who go into healthcare. So nonsense mutations are often what we call stop codon or X mutations, things like the G542X or W1282X, in which there's a premature stop codon, and as the ribosome is reading, you know, through that, it comes to it and it doesn't make protein. It stops altogether, and no protein is ever made. Class 2 mutations are what we think of as misfolding mutations, in which a protein is actually made. A CFTR protein is actually made, but it's an abnormal protein. It doesn't fold properly, the conformation is abnormal, and the cell recognizes that. The cell says, you know what, it's not a protein we want at the cell surface because it doesn't look right. So most of that protein gets programmed for degradation and never makes it to the cell surface. The most common mutation we see in people with cystic fibrosis is the F508del mutation, and that's a class 2 mutation. Class 3 mutations are what we call gating mutations. Mutations in which there's a protein made and a protein that actually makes it to the cell surface, that's trafficked to the cell surface. But again, it doesn't fold properly and it doesn't open properly. It doesn't gate, so you don't get chloride secretion into the airway. Class 1, 2, and 3 mutations are what we refer to as being absent function mutations. So people with cystic fibrosis with these mutations will typically have a severe form of cystic fibrosis, where severe lung disease, severe digestive disease. There's also what we refer to as class 4 and 5 mutations. Class 4 we refer to as conductance mutations, in which there's a protein that works at the cell surface, but it works suboptimally. So you get reduced chloride secretion through the channel into the lumen of either the airway or the digestive tract. And then class 5 mutations are result in proteins in which the protein actually functions pretty normally. You get normal secretion of chloride, but it's a reduced number of CFTR protein that's actually made, produced, and trafficked to the cell surface. And these class 4 and class 5 mutations are what we refer to as residual function or partial function mutations. Typically, people with these mutations in class 4 or class 5, you know, they often don't need to take digestive enzymes when they eat and drink, and they have less severe lung disease. That's a general thing. All right, so thinking about how we approach mutations, because we're in this era of precision-based medicine. What does that mean? Precision medicine is where we can use a treatment based on somebody's underlying genetics. So we have treatments that target particular gene mutation abnormalities in cystic fibrosis. So if we think about the first class of mutations, class 1 mutations, which people have a G542X or a W82X, in which no protein's made, we're looking at agents that we call translational read-through agents. So we have not been successful yet with this class of therapeutics, but there are several treatments under investigation and in development in this regard. And these are therapies in which it allows you to read through that premature stop codon and still make a protein. Now that protein may not be totally normal, but if we can get the protein made, get it to the cell surface, then we can act upon it. Class 2 mutations, I mentioned, like the F508 mutation, in which a protein is made, but it's not a normal protein. Most of it gets programmed for degradation through the proteasome complex in the cell. Well, we're using a class of treatments that we refer to as CFTR correctors, which facilitates it. These are small molecules that bind to the protein inside the cell. They change the conformation of that protein, facilitating the processing and trafficking of the CFTR to the cell surface so that we can then act upon it at the cell surface. So CFTR correctors is one form of CFTR protein rescue treatment, or this class of treatments we call CFTR modulators. The other one is what we call potentiators. So potentiators act upon the protein or the CFTR protein, the anion channel at the cell surface, where they potentiate or open the channel probability of CFTR at the cell surface, allowing chloride to flow through the channel to go into the lumen of the airway or the digestive tract. So let's take a look at how this works. So this video is showing you right now a CFTR protein, that's in the cell surface. But and this is an example of a patient with a G551D mutation or a gating mutation, where again the protein's at the cell surface, but it doesn't open properly. So here you see it's there at the cell surface, but it's not open. Chloride's not flowing through. The small molecule binds, opening the channel, allowing chloride to flow through. So that's the idea about ivacaftor, and that's a nice video animated file. The question is that how it works in the real world? Well, the answer is yes, it does. And so I'm just simply showing you data from the phase 2 and phase 3 clinical trials that were published at the beginning of the decade in 2010 and 2011, and led to the very first CFTR modulator therapy, what we call ivacaftor, or the trade name is Kalydeco, that was approved for people with cystic fibrosis in 2012. Again, it's a potentiator. It functions on that CFTR protein at the cell surface, opening the channel. And I'm showing you two outcomes in the clinical trials. One is the effects of this medicine, or ivacaftor, on lung function, on a measurement of lung function that we call FEV1, or forced expiratory volume in 1 second. This is an important outcome measure in CF clinical trials. It's also a very important measurement of how somebody is doing with cystic fibrosis. Every time I see a child with cystic fibrosis in clinic, they do a lung function measurement where I measure their FEV1. It tells me how their lungs are doing. And in this clinical trial, the patients randomized to ivacaftor experienced a greater than 10% improvement in lung function in their FEV1 that occurred immediately within starting treatment and was sustained over 1 year of the treatment trial. And from a biology perspective, so we think that this is working by improving CFTR activity in the body. Well, it turns out we can measure that. We can measure that by doing a sweat test. So in the graphic here on your right, we're looking at at sweat chloride. That people with cystic fibrosis tend to, in this particular mutation, tend to have an average sweat chloride of about 100. And we measure it in units of millimole per liter of sweat. Most of you in the audience, most of you watching this virtually, have an average sweat chloride of about 22. But people with cystic fibrosis, a diagnosis of cystic fibrosis actually is a sweat chloride greater than 60. So these people in this clinical trial had a starting sweat chloride of about 100, and then with initiation of ivacaftor, it went immediately down on average greater than 40 to 50 millimoles per liter, taking them below that diagnostic threshold of cystic fibrosis. Now, they still have cystic fibrosis. Their CFTR is not working perfectly, but it's working significantly better. So again, this is the biologic correlate that gave us confidence that this medicine truly is working in people and led to the approval of ivacaftor. Now, eventually, a few other CFTR modulators have been approved over the last decade. There were these dual combination medicines, one that consisted of a corrector lumacaftor with a potentiator ivacaftor, another combination with the corrector tezacaftor with the potentiator ivacaftor. And both of these dual combination medicines have been effective for a larger segment of our CF population, but they have been modestly effective, meaning they work, but not as well as ivacaftor does in the G551D mutation. So we needed better treatments. We needed better treatments for people who qualified for these modulators, and we needed better treatments for a large majority. And that really came to fruition last fall. It was really shortly after I gave this medical careers class presentation last fall that we learned the phase 3 results of a triple combination CFTR therapy that consists of 2 CFTR correctors, elexacaftor and tezacaftor, in combination with a CFTR potentiator, ivacaftor. And this triple combination therapy is highly effective. To just sort of show you an example from the clinical trials, this was one of the phase 3 clinical trials in which it was studied in patients who are what we term heterozygous for the F508, meaning they have one copy of the F508 and their second mutation was a different mutation, but also a minimal function mutation. And again, just like we saw with ivacaftor, was a significant, immediate, about 14% improvement in lung function in these people treated with the triple combination relative to the placebo. And the placebo group, just like the placebo group with ivacaftor, does what a placebo group does, which is if we go back, sorry, I messed up there. We go back here, placebo group drops over time. That's what typically happens. People who cystic fibrosis typically lose lung function over time. So, but in this case, we have an improved lung function that's sustained over the course of, in this case, it was a 6-month clinical trial. We also, this therapy also showed a pretty dramatic, greater than 60% reduction in the frequency of pulmonary exacerbations. These are respiratory illnesses that require antibiotic therapy and often require hospitalization and IV antibiotic therapy. So this was, really dramatic. So this triple combination was approved for people with cystic fibrosis last fall. And we started to prescribe this for our patients, last November. So truly a breakthrough treatment for many of our patients. But the next breakthrough I mentioned is going to be in being able to either replace the gene with something we call gene therapy or repair the gene with gene editing. Or another strategy is actually RNA-based therapy. And so this is a video put together by the CF Foundation. It sort of highlights these strategies and trying to develop the next era of gene-based therapy. So let's take a look at this. Cystic fibrosis is a complex disease.
The video is working fine. The audio is not working. If you wanted to talk through it.
I'm going to pause things for a second because it sounds like the audio is not working.
That's correct, but the video is working perfectly, but the audio, you can't hear it.
You can't hear it. So interesting. Okay, so I'm going to, okay. All right. Good to know. Let me just see if there's anything. What I may do is, all right, it sounds like the audio, guys, is not working. So I'm just gonna talk through things as it plays. Actually, I'm gonna go here. I'm gonna end for one. Let's see if I can just turn up the volume. I'm gonna pause this for a second, guys. Let me screen share again. All right, so we're going to try again. Chris, let me know if we're hearing anything. Hang on one second, it hasn't started.
Cystic fibrosis is a complex disease.
The audio starts and then it just fizzles out right then and there.
Okay, so you still don't hear the audio.
It starts at the very beginning. It says cystic fibrosis and then it fades out completely.
Sounds great. So what I'm going to do is I'll just share. It's actually a YouTube file, and so what I'll do is I'll share that with you, and the link to that, and you can send that out so that people can watch this as well. That way they can watch it. You share that link with the students. But I'm going to just play it, and I'll talk along.
Okay.
Here's the gene where you see the mutation in a CFTR gene, which then tells the cells how to make the CFTR protein. The CFTR protein goes to the cell surface where it controls the movement of water and salt into and out of cells. But in CF, the mutated gene, has abnormal instructions, and as a consequence, the protein doesn't work properly, mucus builds up. So we'll look at therapies that are being developed to treat this, first starting with RNA type therapy.
Gene editing would repair CFTR mutations. Each of these techniques remove the mutation. To fix this damage, gene editing can either be gene editing changes the DNA permanently.
So Chris, you still could not hear that. Is that correct?
Yes, that's correct. I couldn't hear.
Okay, so to the group, I'm going to send you a link to this video file that is available to all of you publicly on YouTube and stuff where you can watch. It's about a 4-minute video, and allows you to learn more about these different therapies. There's a lot of work that's going in to figure out how best to deliver these therapies. Again, a lot of the disease and big reason for the morbidity and mortality in cystic fibrosis is the lung disease. So we're looking at inhaled therapies, but inhaled therapies won't fix the CF gene in other parts of the body, in the pancreas, in the digestive tract, in the liver. And so we're also looking at systemic therapies. And so ultimately, figuring out how best to deliver these gene vehicles. The video talks about vectors, where we're looking at sort of viral vectors. I think many of you are aware of this pandemic. There's a virus that gets in our respiratory tract, the SARS-CoV-2 virus, resulting in this COVID pandemic. Well, we're looking at similar type of viral vectors, but specifically adenoviral vectors or lentiviral vectors that allow us to be able to deliver genes into the body, such as by inhalation. So anyways, it's a really neat video segment that allows you to think about gene therapy. And this has implications beyond cystic fibrosis. It has implications for a lot of different gene-based diseases that we treat as physicians. So anyways, I'm ending here with pictures of children and adults with cystic fibrosis. It has been a great opportunity to present to you guys. I look forward to being able to speak in person again in the near future. I think this medical careers class is outstanding. I'm thrilled that Mr. Stirrups led it for the last several years. And again, thank you for the opportunity to present. If you guys ever have questions, don't hesitate to email me. My contact information was on the title slide. So thank you.
Great job, my friend.
Thank you.